what most of us, and I certainly wouldn't have known it until I went to dental school, but your tongue is what forms your midface. You have two lateral plates of the palate, and you have a premaxilla that come together in utero. And when you start the sucking and swallowing reflex, your tongue should go up into your palate and press against the palate, because when you come out into this world, you're going to be nursing and getting your nutrition through that. But if your tongue is too tightly tethered to the floor of your mouth, you can't get your tongue up into your palate. And it's the old adage, form follows function. So if your tongue can't function properly, the form of your palate, the form of your lower jaw can be greatly distorted. And so what happens is the picture on the left shows a tongue as it fits up into the palate. And the teeth erupt in this corridor between the tongue, the cheeks, and the lips. But if the tongue can't get into the palate, you see on the picture on the right that the upper molars are now inside the lower molars, because they haven't gotten the stimulation or the epigenetic impulses or whatever you want to call it to spread that palate out. And it's that tongue in the palate being able to pressure about 2,000 times a day or so every time you swallow that causes, as you grow as a child, for that palate to spread out and make room for your teeth to come in a fully complete and straight arrangement and give you that big, beautiful Farrah Fawcett smile. If it doesn't get up there, you're more likely to have a Jay Leno smile, that long, narrow face, okay? Narrow face, long vertical growth, because Jay, I'm sure, as a kid, was a mouth breather. Because when your tongue doesn't get in your palate and develop that roof to your mouth, it also doesn't develop the floor to your nose, because it's all part of one and the same. So what happens is you mouth breathe, you're breathing in unhumidified, dirty air. Your tonsils are more likely to dry out and get inflamed, get infected. Little kids get earaches and ear tubes, swollen tonsils, and the doctors don't want to take the tonsils out too much anymore. They're kind of changing a little bit. But you're so much more prone to just chronic infections, especially mold and sinus infections and things like that, because you're not humidifying the air that you breathe. When the tongue does get in the palate and you're able to have that wide floor of the nose, you're able to breathe through your nose and exhale through your nose. I don't have that research paper on here, but there's studies that show you perfuse your blood with oxygen when you exhale through your nose much more efficiently than you do when you exhale through your mouth, because there are sensors in the turbinates that create a reflex that opens your alveoli faster and more efficiently than when you exhale through your mouth. And when you exhale through your mouth and breathe through your mouth, you only oxygenate your blood to about 80% as efficiently as you can when you breathe through your nose. Plus, when you breathe through your nose, as most of you I'm sure are aware of, you create nitric oxide, which is the greatest antioxidant out there. So you're not breathing through your nose, you don't get good air, you don't produce nitric oxide. When all this first appeared to me in 2003, I really didn't understand. I mean, Robson had a lot of great things that he talked about, but we never talked about this function. It was just the fact that the airway was blocked, but we never asked why. That's the sad part. I'm standing up here explaining this to you, but I've been working with this stuff since 2003, and it wasn't until 2 years ago, and I looked under the tongue and went, well, dadgum, no wonder the tongue doesn't want to go up there. It's too tightly bound to the floor of the mouth. I mean, how slow-minded do you think I am? I'm pretty slow. But Robson never mentioned this either. And so I started doing research on it. I've been doing tongue tie releases on newborns for several years. And again, this shows you the arch form when the tongue does get in the palate versus when it doesn't. But I've been tongue ties on newborns for years because they can't nurse properly. They can't get their tongue under the breast or the nipple well enough to create a good seal, or they may have a frenum up in their lip, the labial frenum that may be too tight, and they can't get their lip around the breast or nipple well enough to create a seal. So I do those, and I do it with a laser, and you just really just go in real quick and melt this tissue. But if the tongue can't be elevated into the floor of the mouth, Your tongue is almost like a cushion or a pillow, but it's folded in half. And the flatter it gets, the longer it gets. But you've got your teeth out here, hopefully, to block it. Okay? So it's going to go like this. As you flatten your tongue, it's elongating like this, front to back, anterior to posterior. Okay? But when you keep your tongue up in your palate like you should be, you shorten it, it swells up. And if you'll make a note on your pads today, when you go home today or when you get to your hotel, go on YouTube and pull up the video of the opera singer in the MRI. There's a guy singing in a MRI, and you're going to see a tongue that you won't believe a tongue can do what this guy's tongue does while he sings. I'm going, oh my gosh, I never knew a tongue can do that. But if the tongue can't get up in the palate, it's got to go somewhere. So it's either going to go down the throat, and here you see these examples of oral dysfunction. The one on the left, this person has a lateral tongue thrust. They got to get their tongue out of the way so they can swallow and create a seal. The one in the front has an anterior tongue thrust. Okay? Here's some more. And you see in these pictures how narrow and V-shaped the arches are. Okay? Crowded teeth, things like that. This is a recent patient I had about 3 weeks ago. This guy's been a patient of mine for about 4 or 5 years. And he wanted a sleep appliance. But he's real cheap, and he didn't want to pay for the really good one that lasts for about 15 years. So about every 2 to 3 years, he comes in and I remake this little thing I call a diagnostic sleep appliance. And but you see here on the picture on the right, those lumps on the inside of his mandible. Those are called tora. And that's what Robson was looking at, when he came up with all his airway stuff. He was why does God make tora? Is he trying to lift the tongue up? And so he made these little oral appliances that fit on the lower jaw that help stimulate the tongue to move up and forward a little bit. And it was amazing. Dr. Cowden went out there with me right after I first saw this guy. I called him and said, Lee, you got to come see this guy, what he's doing. It's ridiculous what he can do. And the most ridiculous thing he did was a guy that was a very established, wealthy real estate developer in Seattle and Tacoma. He developed MS, but he had been in a car wreck and developed TMJ problems. So he comes to Robson. Robson's working on his TMJ. And he says, let's see if I can help you. The guy could not pick up a pencil. Robson made him one of his little appliances and worked and worked and worked and worked. I mean, he worked for about a year trying to get this thing just perfect. And when he did, the guy could pick up a pencil and write his name. He could have his mouth. He couldn't pick up the pencil. He kept working on it and got the guy out of the wheelchair. The guy gave Robson a building and built a teaching facility for him to teach other people about that. And that's kind of where I came in on this deal. So it's really quite powerful. But his whole thing was, why does God make Torah? But he never asked about the tongue tie.